Good morning, everyone, and welcome to the House Committee on Health and Human Services and Elderly Affairs. We have a hearing on a non-germane amendment to HB 1585 that we'll be talking about momentarily, and then we'll be going into executive session later. But before we do any of that, I'd ask you to please join me in the Pledge of Allegiance. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. Thank you, everyone. Okay, the amendment is on, again, HB 1585 0908H, and I'd like to recognize Representative Jackie Grota, who is one of the co-sponsors of the amendment, along with Representative Weber. Please proceed, Representative Grota.
Thank you.
Welcome.
So the 1108 2024 to 1108H was the amendment that had been put together by the, I'll call it the steering committee, the group of people that were responsible for the for actually carrying out this work. And that was the amendment that I presented to you at the, it was a draft amendment. And so this 1198 is the 0908, sorry, is the amendment that we discussed.
Okay, thank you.
Yep.
Any questions for Representative Grota? Representative Leon.
I guess I mostly wanted to say thank you for coming back for this hearing, just so we can make sure that if there was anybody who wasn't part of the conversation, they have a chance, but wonderful work. Thank you.
Thank you. It was a very interesting study in how to draw a bill.
Representative Weber.
And my understanding, Mr. Chair, is that we now have passed out 1198, which is where the source of my confusion was, which is Representative Merchant and Representative Grota's further effort on this. And then there is one small further tweak that we're waiting for. So I wonder if it would be appropriate at this point for Representative Grota also to talk about the differences between 0908 and 1198, just so that all of the people who are here who are interested have a chance to hear those differences and weigh in if they choose to do so.
Sure, absolutely.
Thank you. So during the last hearing on this bill, there had been concern about the kind of medication that a CALMA could administer in relationship to injectable medication. And of most concern was injectable medication that would be drawn via a vial. So something that has to be determined and measured by the administrator of the medication. It was agreed by the commission and by the committee, the ad hoc committee, and all those involved that indeed that could be something that a CALMA would be prevented to do. So they would be allowed to, for example, use medication that is already dosed, where the syringe is already dosed, such as EpiPen, and but things that had to be drawn from a vial would not be allowed. So the language that Representative Merchant and I had come up with is on page 2, line 32, where it says the criteria for the administration of non-injectable medication in the process of approving, and then again, line 35, common medication administration shall be limited to non-injectable medication unless medication is self-administered. So when we reviewed this with the committee, the issue was that criteria for the administration of non-injectable medications, it has to do with the administration of all medications, not just non-injectable ones, because EpiPens would be considered injectable. And then administration shall be limited to non-injectable medication unless such medication is self-administered. Well, the whole purpose of this bill is if medication is not self-administered. So we asked that we take those two words out of the amendment, and I'm sorry, I keep looking at my phone because the House Community Services, Committee Services is printing up the amendment. Yes.
Just,
Representative Barber.
thank you, Mr. Chair. Just for clarification, what the amendment that is being prepared does is it simply strikes the word non-injectable
And
in two
self-admit.
places.
No.
Is that correct?
It on line 32, it takes out non-injectable,
Okay,
and in line 36, it takes out self-administered.
okay, I'm sorry. Thank you
And
very
then-
much for that
Sure, and
clarification.
then just to be sure that rulemaking is parallel to statute, we are adding that part to rulemaking. It's just the same exact line is being put in the rulemaking, which is also, let me just see where that would be. It is, there's a rulemaking section that was added to this because we need rulemaking, and in that rulemaking, that's where that clause is put, so that the rules clarify as well, the rules and the statute duplicate each other.
Representative Shapiro.
Is the rulemaking portion in this amendment?
It's in the one that you're getting, the one that I'm waiting for.
Thank you.
It's in this one?
Representative Leon.
Thank you, Mr. Chairman. When you noted the issue about medication shall be limited to self-administered medication not withdrawn from a vial,
Mm-hmm.
that language is also on line 6. And then it's mirrored in the rulemaking, and the rulemaking authority is lines 30 through 36 on page 2 of this. And my question was if you were looking to standardize that language. It sounds like they still won't be standardized between the two. Because you sounded like you were removing self-administered from line 36. Are you removing it from line 6 as well?
Yes, I am actually in
Okay.
yes, thank you.
Okay, perfect. And
Yep.
then the non-injectable is removed on both page 30, line 35 and line 32?
I don't see self-injectable on, oh no, non-injectable is okay on line 35, but we're repealing it on line 32. We're taking it out on line 32.
Okay, thank you.
Yes.
Other questions? Representative Palazzo.
Thank you, Mr. Chair, and thank you for taking my question. Coming back to the intent of this amendment, we already have very complex system with many positions that require certification, and it looks we are adding CalMA a new position, making system even more complex. So can you briefly talk why you think this added complexity is justified by added benefits?
If I understand your question, you're asking why this position is being requested in line of, right, because the assisted living facility, so in facilities where people are being cared for, there's different levels of care. And assisted living facilities have the least, they obviously have regulations, but they are the least regulated of all care facilities because the people there are capable of taking care of themselves. It is considered a home for them. And it could be that they are there because they can no longer drive, or there are many reasons why they're there. But it's not nursing care. And so they do not have nursing staff necessarily. But they do have dedicated people who are capable of helping them with the administration of medication. And this is a position that's been created for those individuals. They would have to, though, take a medication class, which is similar to the class that LNAs get. It's a 40-hour class, and it would be administered and put together by the Board of Nursing.
Representative Merchant.
Thank you, Mr. Chair. Thank you, Representative Greta, for taking my question. The intent behind self-administered medication was the fact that when I heard during testimony, they want to be able to use an insulin pen, and insulin pens are self-administered. So that's kind of the root of the word self-administered. There are things like auto injectors and things of that nature that a patient can use to self-administer, but hearing the testimony from the residential care people, sometimes the patient doesn't have the dexterity to do the self-administration, so someone has to do it on their behalf. So that was where the genesis of self-administration came from. And I think one of the things I'm trying to get to is that not withdrawn from a vial helps to protect someone basically at that point in time taking something out of a vial. Like in a hospital, if you have insulin, it's done by two people. Injectable medications are problematic if they're not done correctly. That's my concern. So again, back to the same thing, is that if it's in an auto injector, a pen injector, and so forth, those are things designed to be self-administered. But back to what I said before, if the patient can't do it because of dexterity problems, arthritis, and so forth, it still allows the person to assist that patient.
Well, by putting, unless the medication, first of all, we all agree that any medication taken from a vial cannot be done by a comma. That's something that is agreed by everyone in. And if you put in self-administered medication, that means that the person who's the reason why they need the comma is that they can't do it themselves. So by putting that in, you're limiting what the comma can do. And also know that this is going through rulemaking. This is not going to be the end of the conversation. But by putting it in here, you limit the ability to define what the comma can do. And I think that should be decided for by the Board of Nursing and the assisted living folk and the Nurses Association. I mean, that's.
Representative Palmer and then Representative Weber.
So I just wanted to say why I think this is a very important bill. The number of times I've been stuck in the hospital not being able to discharge a patient because there's no one available in the assisted living facility to give medications, taking up a bed in the hospital over the weekend, having this poor person sit in the hospital exposed to all of us. So I really think this is a kind of critical piece in the puzzle.
Representative Weber and then Representative Leon.
So my question is, and I'm really very glad that Representative Palmer gave us the broad scope here, because what it sounds like to me that we're discussing here with the amendments is a teeny tiny piece. And if I'm understanding correctly, everybody agrees that anything that has to be drawn from a vial or mixed or anything is completely out of the question. The only thing we are trying to do is make it clearer, or at least give rulemaking authority,
Yes.
so that if a patient has a one-time pre-mixed, ready to go, self-administered medication already in a container, like an EpiPen, but with whatever they need in it, that if they do not have the physical dexterity in their fingers, that the CALMA would be able to help them with the administration of a medication that has no mixing or dosing or determining. It's just there and ready to go. And are we, and that the rules for that would be done by rulemaking, where the people whose job it is, unlike ours, most of us, to administer medication, will have the input as to the circumstances as to how that happens. Is that correct?
That's correct and well said. Thank you.
And I just wanted to say thank you to everybody who's here who has worked on this, because I know it's been an incredibly long slog. And we'll keep working.
Thank you, Representative Leon, and then Representative Cushman.
Thank you. My question is about this parsing of the language. If we have the language in your amendment, and then perhaps if the committee report expresses some of those specific concerns about how we craft it, would that give us sort of the direction and the flexibility in GELCAR to make sure that they're appropriately protective and to put that into rules as opposed to statutes?
Yes, and know that as a member of GELCAR, public comment and is all part of the packet that we get, but you can believe I'll be looking for that.
Representative Cushman and then Representative Weber.
Thank you, Mr. Chairman. Can you tell me how this amendment, I'm just trying to think how this is going to work with, say, a patient who has on sliding scale insulin and they have a pen that you need to turn the knob on. Is that something that's going to be permitted through this
That-
certification or no?
Not necessarily, no, because that's a whole different thing.
Okay.
You're talking about a dial pen, a dialing pen?
Yeah.
No, not necessarily. I mean, that's sort of in between the drawing up of the vial and the EpiPen where everything is preloaded. So that may or may not be, I don't know.
Okay. So this is pretty much only pre-filled auto injector one time.
Well, that's the
dose.
one that everybody agrees on. That's
Okay.
correct.
Okay, thank you.
Representative Weber.
And I was just going to ask, isn't it true that if we actually manage to vote this today and get it to the House floor and get it through the House, it also has to go through the body that we cannot mention. So if people are concerned that there is more clarification needed, we have not one but two opportunities, one in the Senate and then the rulemaking. So what we need to do is to keep it moving, get the rulemaking authorization, which sounds to me like it's there. But if there are people who are not comfortable with it, we still have another opportunity to work on
You
it.
mentioned the body that shall not be mentioned.
30 lashes with a wet noodle.
Representative Polazov.
Thank you, Mr. Chair. Can you help me with amendments? So we have hearing on specific amendment, but we have two amendments in front of us. And did I understood correctly that there's yet another amendment being printed? So what's your preference? Do you want us to adopt all three amendments in the order they were received, or can you help me? Thank you.
Well, there are the First Amendment would be fine to adopt. It's up to you. 1198 would be fine. But that was the one that doesn't really discuss injectables. The Second Amendment, 1198, discusses injectables, but it's rather strict and it's not something that would give a lot of leeway to the rulemaking. So the Third Amendment, which is the one that has my name and Representative Weber's name on it, is the one that I would prefer you adopt, but it's your bill, but I hope that you will consider the input that I represent the 26 people who put together this amendment. So I'm taking their position. An amendment, I'm waiting. It's like watching a baby getting born, right? You're thinking, is it ever going to
Mr.
come
Chairman.
out?
Mr. Chairman,
Yes, Representative Merchant.
since we're not going to exact on this until maybe later, could we then at that point in time move this to, wait for the amendment to come in later? Not,
We can't, I mean, again, this hearing is only on the non-germane amendment, not all of the amendments. So much of what we're talking about is fine, but it's really, the focus is on 0908H because that's the non-germane amendment. Did I answer your question, by the way? Or?
so basically we have to have a hearing on the next
No.
amendment?
No, no.
Okay,
No, this is the only hearing we need.
so therefore, what I'm trying, because I don't know how long it's gonna take for OLS to get it to us, if we could.
Representative Weber.
Having had a hearing required on the non-germane amendment that some of us don't think wasn't needed, but we have two tweaks, either of which or both of which can be introduced at our executive session, but we don't have to have another hearing on those. They're very close to what already happened. So, and it's up to the chair, but he may want to take up bills in certain orders depending on the people who are in the room waiting to hear about them. So,
Yes, Representative Shapiro.
I have a question of the chair. Since this is a hearing that seems to be somewhere between a hearing and an executive session with discussion, I'm just wondering if there are other people who are going to speak at the hearing and if we should kind of move on.
Yeah, if we don't have any more questions for Representative Groda, Representative Groda?
Thank you. I just want to make one more comment. I'm sorry. I originally there's nothing wrong with the First Amendment, with the non-germane amendment that we are having a hearing on now, 1198. We can certainly add rulemaking and the other components to it in the other body, and I would certainly support that. But as soon as we get the Third Amendment, as soon as we get the amendment from the one that's from Representative Weber and I will make sure that we have it, that you all have it.
Okay.
But I would encourage the committee to give the rulemaking as much authority as possible. Thank you.
Okay, thank you. Okay, no one has signed up to speak on this bill other than Representative Groda. We do need a pink card from you, please.
Yes, I'll do it right now.
Okay, thank you. I have no pink cards. Does anyone else wish to testify on this amendment? I'm seeing none. Okay, Representative Weber, did you have a comment? No. Okay. All right, if no one else wishes to testify on this amendment, I'm going to close the public hearing. And in a couple of minutes, we'll be beginning our executive session. Thank you. Welcome back. We are now going to open the executive session on several bills. And in deference to our guests lining the walls of our committee room, we'll start off with HB 1568 FN. Representative Leon, do you have a motion?
Yes, just Mr. Chairman, I move interim study, and after a second, I'll speak to it.
Representative Palazzo, do you have a second?
I second.
Representative Leon.
Thank you, Mr. Chairman. I recognize that this is a really pressing problem of unreimbursed care for Medicaid patients. And I recognize it's also complex and challenging. Some of the things that we probably would need to address would be whether the response originated through a 911 call or some other way so that we can understand and have an idea on what is a reasonable one to reimburse as opposed to somebody coming over for something quite trivial and wasting your time. That the patient's consenting to the evaluation, that there's an agreement that the person doesn't need to be transported. I think there's a whole lot of things that need to be addressed. And fortunately for us, we're not the only people who have been looking at this topic. And I expect to see a bill that actually deals with this in a much more comprehensive way hit our committee very soon, as there's some pretty full agreement over in that other body about a much more elegant solution to this problem. And rather than the fact that we weren't able to really have an idea of how to approach it, and they put together something wonderful, I think is a good reason for us to move interim study on this bill, and excitedly look forward to getting to work once it comes over to us. It'd be Senate Bill 409 looks really good, and it's 7-0 out of finance after it had passed a voice vote in the Senate. So this isn't punting the issue. I just think I think that they've have a better start, and we should move to that work instead.
Representative Merchant.
Who was the second tonight, please?
Representative Palazzo.
Thank you.
Representative Weber.
Thank you, Mr. Chairman. I'm very glad that we all support this in theory. My position is that I am not understanding why this bill, which is very simple and in my mind very clear, has been infused with a lot of confusion and difficulty, and it's all complicated. I don't think it's complicated. I think the bill does exactly what's needed. And for that reason, I will be opposing an interim study and hoping to move something else.
Thank you. Representative Shapiro.
Thank you. From what I know about Senate Bill 409, I would agree with Representative Leon that that one is maybe more comprehensive and more detailed, and will give us better guidance moving forward. But at the same time, in principle, this bill 1568, which is very simple and allows us to take a stand saying that we support reimbursement for emergency medical response. This is a policy that we can endorse here and now, and both bills will end up in Finance Committee. And I would think that we, understanding that the finances of this bill have not been well vetted, I think as a policy decision, we can agree to support this and send it ahead to Finance Committee, and that let others deal with the intricacies. So I would also not vote for interim study, but vote for vote against interim study in order to make another motion and support that.
Thank you. Other discussion? Representative Leon.
Thank you, Mr. Chairman. I'm not really in the business of passing messaging. I try and pass bills that actually will achieve what we're looking to do. The details were so sparse in this that this wasn't even a second committee bill, because there was no way to get a handle on what the cost would be. I fully support all of our first responders. I just want to make sure that instead of just saying, yes, we support you, so we'll push this through, we'll look to something that's a very comprehensive one that we can all get behind. And so that there can be some clarity so that everything is directed a little bit closer, and we can get this done sooner rather than later by doing that.
Other discussion? Seeing none. Okay, the motion is interim study on HB 1568. I'll ask the clerk to call the roll.
Representative Leon,
Yes.
Representative Cushman,
Yes.
Representative Bill King, yes. Representative Kofal,
Yes.
Representative McLean,
Yes.
Representative Seth King,
Yes.
Representative Moffett,
Yes.
Representative Nagel.
Yes.
Representative Polozov,
Yes.
Representative Weber,
No?
Representative McKay,
No.
Representative Freitas, Representative Cannon,
No.
Representative Nutter Upham,
No.
Representative Shapiro,
No.
Representative Merchant,
No.
Representative Long,
No.
Representative Palmer,
No.
Representative Tejas,
No.
and Representative McDonald,
Yes.
10-10.
Okay, Representative Weber.
I would move ought to pass.
Okay, is there a second? Representative Palmer seconds. Representative Weber, do you want to speak to your motion?
I think I already have. I don't think I need to belabor it.
Any discussion on the ought to pass motion on 1568? Seeing none, I'll ask the clerk to call the roll, if he's ready.
Representative Leon,
No.
Representative Cushman,
No.
Representative Bill King, no. Representative Kofal,
No.
Representative McLean,
No.
Representative Seth King,
No.
Representative Mazur, I'm sorry, Representative Moffett,
No.
Representative Nagel, Representative Polozov,
No.
Representative Weber,
Yes?
Representative McKay,
Yes.
Representative Freitas,
Yes.
Representative Cannon,
Yes.
Representative Nutter Upham, Representative Shapiro,
Yes.
Representative Merchant,
Yes.
Representative Long,
Yes.
Representative Palmer,
Yes.
Representative Tejas,
Yes.
and Representative McDonald,
No.
10-10.
All right, that'll go to the House with no recommendation. And I know I don't need to remind either of the authors, but we need those reports in ASAP with the deadline this morning or by early afternoon. Representative Leon, Representative Weber, thank you on those. Okay, moving on to the next bill, HB 1280, relative to informed consent and patients' rights. Representative McLean, do you have a motion?
I thought there was gonna be an amendment. No, no? Okay. Then, I would move, ought to pass.
Okay, Representative Cushman, do you have a second?
Second.
Representative Cushman seconds. Representative McLean, do you wish to speak to your motion? Yeah. Cushman.
Bushman.
Yes, thank you, Mr. Chair. So looking at this legislation, the reason I think I'm going to support this legislation is because I think what it does is it puts forth a kind of a minimum standard for patient care and informed consent. And I think that if you look at the provisions that are in the legislation, it's a very low lift. So we're very fortunate in this committee to have a lot of healthcare professionals who are part of our team here. And I think if they ask the question of themselves, is there anything that is contained in this that they would not want to do? No, I think they would all say, yeah, all of the stuff that is contained in here kind of makes sense. And I said, it's kind of a minimum bar. So as I said, it's a pretty low lift. So the question for me anyways, when I was considering, where to go with this is it necessary though to put it into statute? And I think my answer to that question is yes, because I think if you look at the way that healthcare has progressed in the last 30 years, you're seeing a development of a very, very broad administrative infrastructure. And I think that kind of changes the way that healthcare is delivered now in contrast to the way it was delivered 30 years ago. I think of myself, 30 years ago when I was engaging in the healthcare profession, I had a very different experience than I did now, both with respect to follow-up care, with respect to the kind of discussions that I would have with the doctors. And, in contrast with that, I was down in Brazil and I had a pneumothorax. And so I had to go in and I had to receive care in Brazil. And I didn't speak a word of Portuguese really. So they had the doctor in, the doctors didn't speak Portuguese. There were all kinds of discussions, and all through the process and after, the amount of follow-up care was just incredible. And when I look at a couple of years later, I had hernia surgery here in the United States. There was nowhere near that level of discussion. And even when I was asked, it just really wasn't available to me. And the same thing I encountered, with the follow-up care. So I asked myself the question, if I look at Brazil's doctors and nurses and the doctors that we have now versus the ones 30 years ago, are they better in Brazil? Are the doctors from 30 years ago better than they are now? No, I don't think so. I think healthcare professionals today are just as committed as they were in the past. They have a sense of mission, they have a sense of purpose, and they're patient-centered, but they have this administrative infrastructure that has grown up now in healthcare. And what that administrative infrastructure, I think, tries to do is it tries to treat healthcare as a process. And once it does that, it looks for efficiencies and opportunities to introduce lean. And I know this because, I'm an engineer and that's what I would like to do with my processes. But I think it's very hard to introduce the concept of lean to a discussion between a doctor and a patient. I mean, sometimes it's going to be a 5-minute discussion. Sometimes it's going to be a 30-minute discussion. And when I talk to both patients and doctors, I hear from both sides, there's some frustrations about the limitations around that. And so, again, do you need to have something coming in from the outside necessarily in the form of statute? And as I was thinking about that, I thought back to the early environmental movement. And I remember back being a kid growing up, going to the Reversing Falls and just looking at the pulp effluent coming down the river and all the smog that was in the air. And there needed to be an outside influence to kind of move that. And I think maybe the environmental movement has gone a little bit in one direction, but the intention when it first started off was we need to bring in an outside influence to kind of move things back towards the center. And I see that that's kind of where this legislation has value, because it does kind of set from the outside, from statute, that minimum threshold that you have to maintain. It's a very low bar that I don't think most healthcare providers would object to. And it's I think going to be a valuable tool both for patients and for healthcare professionals. And so I hope everybody will support it.
Representative Cushman, did you wish to speak to your motion? Or?
I don't really have anything to add to that. I think Representative McLean presented it perfectly. Thank you.
Thank you. Representative Tellez and then Representative Nagel.
Thank you, Mr. Chair, and thank you, Representative McLean, because I think reminding us of the administrative infrastructure that's been growing and some frustrations and limitations is part of what's been happening with healthcare, and this bill has absolutely nothing to do with an ability to impact that. This bill was introduced without any evidence of the need for it. It would be administratively burdensome. It's the standard practice of care, as most of the physicians in the room have already explained. And the way you improve healthcare is not by legislation. There are many, many means by which to try to make things better, both within each individual practice, organization, or overall, as sort of the practice of medicine as a whole with guidance and all that. And I think that if I had clarity on any evidence that there was a need for this, I might feel differently. But as someone who does teach quality improvement and has worked in, trying to improve health for a very long time, I really am scratching my head about this and would definitely be voting against it.
Representative Nagel and then Representative Leon.
Thank you, Mr. Chairman. I agree with both of you. If I can do that.
We don't understand how you can do it.
Now
but
I
you
have
do
to
it.
explain it. I'm not gonna say it without explaining. I mean, superficially, I thought that this bill was a waste of time for every reason you just said. I mean, everything that's in here, we already have to do. However, we've seen what we call corporatization or invasion of the medical industrial complex into healthcare, where within the next 10 years, we're all going to be employed by a corporate entity of some sort. I see this bill as protecting not just the patient, but the doctor from that. And I will share an example with you. Yesterday, I had nothing better to do in my OR time than to look at informed consent that we were requiring the patient to sign and that I had to sign too. And these are brand new, hot off the presses, designed by the risk management people with very little input from the doctors. And I looked at this thing and I said, this is an absolute joke. I said, I can't sign this in good faith. So what we did was, with every patient I saw, all 12 of them, I had to go through it and cross that out, cross that out, cross out. This doesn't apply, that doesn't apply, add other stuff. By the time we got done, what was supposed to be a 20-minute visit turned into a 45-minute visit. And that's what we're seeing now, is risk management people designing these things. And that is just totally wrong. What we need to do is go back the clock 30 years and do what we did 30 years ago, where you actually explain things to people and not let people in risk management do it for us. And I think that this bill actually protects doctors. For the longest time, I tried really hard to come up with a reason to not vote for it, and I am going to vote for it for that reason. Thank you.
Representative Leon. No, okay. Any other discussion? Representative Palmer.
So I think that I started off with this same thing, which is that it's kind of redundant since we basically follow the same things. What I'm afraid of is that instead of corporate medicine telling us what to do, the state will tell us what to do, which, and who's making the rules here and who's going to decide? I mean, so there's line 15C, and it says the burdens, risk, and expected benefits of all options, including foregoing treatment. So now, I mean, I would sort of argue that if you have the corporate medicine, they're just going to go there, well, there's this law, we don't want to get sued, and who's made the list of all of the complications, all of the options that need to be documented for this procedure? So, I mean, I'd want this, before agreeing to support this, I'd want a lot more clarity on exactly how it's going to work. And I'm sort of figuring it's going to end up being that I work in the Dartmouth-Hitchcock system, and that there's going to be a new edict beyond what we already do with peer review that's going to, be yet another layer of stuff in getting consent for anything than we have to do now. And it's going to take 10 more minutes. And the people who are paying me aren't going to give me any more time to do it. They're going to expect that it gets done. And if I can't leave till 8 o'clock at night, now admittedly, I don't do a lot of procedures, so it's not as big a burden for me as it will be for a surgeon. But I would only support looking at this further. I wouldn't support passing it today.
Representative Leon.
Thank you, Mr. Chairman. I'm really having a hard time with this discussion. So this is directly from the American Medical Association, from their ethics. This is what is required of doctors today. Our administrative rules say that you need to follow the ethics. If it's going to be burdensome to comply with this, if it's going to be different than what's done today, when our administrative rules say that you need to follow the medical ethics guidelines from the AMA, then that proves just how necessary this bill is.
Representative Palmer.
So, given that we follow the ethical guidelines for consent, the problem is that the way things work these days in the system I work in is that once you have a new law, the lawyers all get involved in that law, and they make the steps that you have to go through to now follow the law the end result should be the same. It should be that we are explaining to patients what we're doing, what the complications are, what their options are. I'm not arguing that, but what I'm saying is that putting it into law will make extra steps. It's already hard enough to recruit physicians to New Hampshire as it is, and every one of these little steps adds to the administrative burden. And, you know, I can sort of see that it sounds like I don't want somebody looking over my shoulder and telling me what to do. They already are. I'm on our peer review committee at the hospital. We already watch very carefully what people are doing, and so does the Board of Medicine. I just think that putting it into a law without sort of more clarity about how it's going to work and how we're going to avoid unintended consequences of making physicians' lives just more difficult without actually making things safer for patients.
Thank you. Other discussion? Representative McLean.
Representative Merchant had his hand up first.
Sorry. Okay, Representative Merchant.
Thank you, Mr. Chair. One of the things I looked at is in the Patient Bill of Rights, which deals with residential facilities and also hospitals, deals with most of this. So there could be a question about a conflict between that Bill of Rights and this trying to create another Bill of Rights. Number two, when you look at constraints, in essence, if you're taking care of a patient and you don't have informed consent, there are standards that are going to have to be met. You have insurance companies will be breathing down your neck if you don't meet those standards, called liability. You can get sued. So I think it's self-governing. We don't need to have a statute to enforce the standards that are out there, whether it be Joint Commission, whether it be AMA. There's enough in the marketplace now that's going to protect the patient from that kind of activity, and to have redundancy in the statute. And when you put it in statute, it's very difficult to change. So if things down the road come up, we want to change things, you can't go through JLCAR and rulemaking to make the modification to a law, you back to the legislative process. So for all those reasons, I think the intent has merit, but I think having something in statute dealing with this is an overkill. Thank you.
Other discussion? Representative Nagel.
I'm just offering a solution. I mean, we're hiring all these quote physician extenders or whatever term we want to use for them nowadays. You know, when my son had his surgery done in Colorado, the doctor spent 2 minutes with us, and he was brilliant. I mean, my son had a horrible fracture, and the guy did an amazing job, but he only spent 2 minutes of it with us, and 30 seconds of it was spent telling us how wonderful he was. Then, you know, and in the end he was, so it was great. But his physician assistant spent 30 minutes with us doing this at a substantially lower cost to both the hospital, the system, and us. And we got all the care we needed. We got all the questions we wanted answered. And I'm struggling because at least in my practice, they don't do that. And I said, well, why are we hiring you? That's the point. I mean, I don't see that the doctor needs to necessarily do this. You have other people within your office that can do that. But we've had several bills come before us where patients are saying they're not getting this. And that's the impetus behind these bills coming forward, like the circumcision bill and, you know, the other bills. There was another bill in there also. And I see, I'm going to get in trouble saying this, but I see this every day where in that 2-minute visit, patients aren't getting this. And they have the right to get it. They're paying a lot of money now between incredibly high deductibles, incredibly high co-pays, and time away from work, and this and that and the other, come see the doctor, and then they don't get this information. And I it's a really troubling thing to me, and I don't like the idea of putting in statute either, but a stand has to be made that we got to stop doing that. You know, we're here for you. People are paying for our services. They are a customer. We are a provider of a service, and they have the right to have that heard. And if this is the only way it's going to get done, and that this momentum in the wrong direction needs to be stopped, then fine. That's why I'm supporting it. It took me like, well, I don't know when you brought the bill up, but I mean, I remember one of the lobbyists and I looked at it and says, why is this a bad bill? We couldn't figure out why. And, you know, that I came around to the thinking that it's unfortunately needed and issues that happened which is why I'm kind of like ticked off right now. But issues that came up yesterday in my practice, this finally just said something's got to get done.
Representative Leon and then Representative Tellez.
Thank you, Mr. Chairman. So the Patient's Bill of Rights was brought up. That is not binding on providers. The Patient's Bill of Rights is for the licensing. It is for the facilities. So the Patient's Bill of Rights doesn't impact what the providers have to do. It does throughout the contracts and that sort of thing. We have another bill today that I'll be recommending for interim study because we're trying to tell the doctors what to do within the facilities language for Patient's Bill of Rights. So we need to make sure that any protections we put in are actually impacting the group of people who we are attempting to speak to. So we can't speak to physicians directly through the Patient's Bill of Rights. And second, I don't know how this is bizarro world. In some places, the party you wouldn't expect to be the free market one is pushing for it. Here, I feel like one party has traditionally been for the underdogs, and here we are fighting for the underdogs. I know I've always been for the underdogs, but I don't know why we're not putting patients over systems. And I think that this bill puts patients over systems.
Representative Tellez and then Representative Shapiro.
Thank you, Mr. Chair. I think there's a few things. I think, Representative Nagel, I think you need to have some conversations with your coworkers, because as an organization, it sounds like there's some, like improvements that could happen based on your own observations that you're sharing with all of us here. I would add that if we really want to incentivize improved care, there's many other ways to go about doing that. We could say we have a survey where we assess patient satisfaction with, the process overall, like being informed, understanding the process of consent. You could incentivize that at organization levels, and then organizations would work together to figure out, okay, do I add an extender, an educator, because right now putting the burden on the provider in the encounter where, as Representative Palmer pointed out, you're still going to be expected to only see the patient in 20 minutes, which basically means it's going to be an even crappier job, excuse me for my blunt language, if now there's more administrative burden to doing what is already happening, which, as Representative Nagel explained, it's about the conversation. And as also Representative Murphy has described, it's about the relationship. So you have a relationship, you have a conversation, and this is introducing a lot of administrative complexity that, again, the lawyers, the administrative types are it's just going to create a lot of additional burden that is not ultimately going to improve patient care. It is going to make everything a lot harder. And I've seen no evidence of anything where this is beneficial.
Representative Shapiro and then Representative Weber.
Mr. Chairman, could I assert a point of personal privilege, please?
Sure, okay.
I really resent the characterization that this is one set of people prioritizing patients over systems and another set of people prioritizing systems over patients. You may believe that that is the result, but I think that you have attributed motive to a whole bunch of people in this room who are very concerned about patients, patient care, patient rights, and we have reached a different conclusion. And so I think that the assertion that one set of people is defending systems and not patients is completely uncalled for. And I thank you for the privilege.
I apologize. I did not mean the offense that came from that. I want us to make sure that we understand who's at the root of each of these choices.
And I do understand that what we're looking at is we're discussing the results, not the intent.
Representative Shapiro and then Representative Merchant.
Yes, I would just like to piggyback on what Representative Tellez said, which is that informed consent, in my mind, is really about a relationship, a conversation. It's something that probably many providers are not that good at. We're not trained in that well. And it's also affected dramatically by the changes in healthcare and the speed up and the productivity demands. I think there's tremendous amount of things that are broken in our system. And, personally, I'm not, although it's been broadly categorized as people are hearing from their constituents that this is a problem, this is not the problem that I'm hearing about. And I hear about a lot of problems in medical care. But I think this is maybe one of those things that's more of an art than a science, that some physicians, some medical people are very good at. I don't see this as a solution to the problem of people not having the time or not having the ability to have delicate, sensitive conversations with people about what their care is going to entail. I'm also concerned specifically about the line 9 through 10 about assessing the patient's ability to understand what we're talking to them about, which of course is part of the responsibility of every provider. You don't want to just talk to people and regardless of whether they understand what you're saying or not. Any provider, I think, would have that in the back of mind. But I think this particular language opens providers up for lawsuits. I mean, like, how does one assess that someone fully understood what you were talking to them about? Do they have to get in some cases, if someone has dementia, do they have to get a specialist in dementia care to figure out if they understand? And I think just the specific language is a concern to me because it kind of creates the expectation that a provider in the course of a short conversation, and let's face it, we don't have time for extremely long conversations, is going to be able to fully assess whether someone comprehends all aspects of that informed consent conversation.
Representative Merchant.
Thank you. Thank you, Mr. Chair. Out of curiosity, this bill is written, it's going to apply to physicians and surgeons, but there's no reference to the same issue with naturopaths, nurse practitioners, and dentists, oral surgeons. They also have the same issue, if you want to talk about it that way. So I think about the narrow scope. We're talking about one type of healthcare provider. We're not talking about other people that we possibly could have the same issue with. Number two, when you start looking at the issue here, this is coming from my own experience. I know some wonderful, wonderful surgeons that technically are phenomenal. I mean, I would trust my life to them, anyone's life to them. They're just phenomenal surgeons, but they may not have the best bedside manner. So trying to regulate bedside manner, which is a sensitivity, which is a lot of what this bill is all about, I think is going in the wrong direction. So therefore, what I'm trying to get to is that we're not being comprehensive. We're taking one type of healthcare provider and trying to have that informed consent apply to them only, when there's other ones out there could be just as devastating, if not more so. And also looking at it and saying is that if we're talking about trying to control bedside behavior and sensitivity interaction with the patient, I think it's more like someone said, an art than a science. And we have to allow for that flexibility and try to legislate it.
Representative King. Seth King.
Thank you, Mr. Chair. I'm very curious about what Representative Nagel has been talking about. My question for you is, do you find that because time constraints and money and issues like that, that there's sort of a perverse incentive not to provide as much informed consent? Because, if you were to really spend the time, not necessarily the doctor, but maybe your staff were to really spend that extra time, that, you're able to see less patients as a result, which means less income for the firm. And if you know that your competitors, so to speak, are cutting corners on that they are going to get a greater market share in the long run. And so, this happens a lot in all sorts of industries. It's like, for example, we don't let, athletes take steroids, because if we let a few of them take steroids, then the rest, in order to compete with them, are going to have to take steroids too. And so it's sort of like a race towards a really bad outcome. And I'm just wondering if you think that part of the reason why so many don't give the informed consent that they should is because they just know that they've got to keep up with expectations and how much money they have to make. And if they knew that there was a level playing field, that, okay, I can spend the time with the patient that's necessary to get them informed consent, because I know that, you know, I'm not going to lose market share by doing that. Does that make any sense? Am I thinking about this correctly? Thank you.
I'm gonna probably plead the fifth a little on this one, but you know, I can speak for me. I can't speak for everybody else. I've been very fortunate in my career. I'm in a private practice. I can do what I want. Nobody's ever told me, what I have to do. My wife is a nurse practitioner, and, I've seen what happens when, certain entities take over practices she's been in and how things change dramatically. However, my wife's probably the most wonderful people I've ever met in my life. My wife has always stuck to her guns and her morals, and it has cost her jobs because she takes more time than other people do, and that bothers me a lot. With that said, you know, I've always included the informed consent from every visit from the beginning we start to the minute we end. So the education goes through the entire time, and I spend a lot of time with people, but I'm like really lucky. I also kind of was on the ground floor of creating a procedure that generated an awful lot of revenue that paid me an awful lot of money. So, you know, it's not like, you know, over 37 years. So it's kind of like I'm not the right person to ask. I can't speak for other people. I don't know why they do what they do. I think what Representative Merchant said, some of it's just personality. One of my best friends right now, when I first arrived, he was one of the most prominent doctors in the state. And he had a reputation for a horrible bedside manner, but he was an amazing surgeon. And you know, patients really couldn't stand talking to that guy. So I got to talk to him a couple months, or I don't know, it was like 2 years ago, and he looked at me and he says, "Dave, since you said crappy, I can say this." He said, "I was really a prick, wasn't I?" And I go, yeah, you really were." And I said, "But that's all right, because you use people around you to help convey the information you weren't doing." And so I'm going off on a tangent on what you said, but to answer your question, it's up to the individual. You do what you think is right. If you bow to pressure, you have to live with that. That's all I can say.
Representative Cushman and then Representative McLean.
Thank you, Mr. Chairman. So most of the concerns here are kind of moot because this is, again, already in administrative rules. So any legal concerns that are being raised about attorneys are going to start looking at it, and then, you know, that where were they? Because administrative rules have the force of law. I mean, this is a very simple bill that supposedly physicians are already doing, and it's just putting it in statute so that we have it concrete. So if the AMA changes and says you don't have to provide informed consent at all in their ethics, which is very unlikely, but it's in statute and it's the standard for our physicians. You know, it's already there. It's clearly workable. There's nothing preventing doctors from using their power of delegation to carry this out. There's nothing preventing a standardized form from offering this required information to the patient, and as long as there's, you know, opportunity for feedback and questions. I mean, I think it's very simple, it's very straightforward, and it's doable, and it's already expected. So I'd appreciate your support. Thank you.
Representative McLean and then Representative Leon.
Yeah, thank you, Mr. Chair. As a lay person, but as a patient, I look at this and I think this is a pretty light lift. I look at it and I think that this is actually just the floor. And I understand and I respect, you know, and I kind of agree with Representative Merchant's comments about, you know, the fact that this is not, you know, fully comprehensive. And I acknowledge that. But I don't think we want to let, you know, the perfect be the enemy of the good. And, you know, we can always come back in the future and add to this. But I think, you know, in spite of the good work that Representative Tellez is talking about that's being done, I think just look at the evidence around us. We are on a trajectory where things are becoming more and more and more perfunctory in spite of all those best efforts. And so I think, you know, we're at a place where The time is here to say we need to have an outside push, and that's what this provides, you know. And I'll go back to the example of the environmental movement. You don't want to go back. I worked at a coal generation facility back in Canada, and we had these electrostatic precipitators, but the cost of using them was very high. Well, an outside agency came in and said, "You're putting too much stuff up the stack, and this is the rule change." Well, guess what? They fired up those ESPs like nobody's business. There comes a point in time when you've got 30 years of internally trying to push it in a direction, but anecdotally, in my experience as a patient, I'm not seeing it. And the discussions I had with other people, they're not seeing it. And if it was going up and down and seesawing, okay, maybe. But it just seems to be this. So you have to introduce something from the outside. And that's why I'm saying, because I'm not a fan of going the statutory route myself. But I think there has to be an outside impetus. And that is, I guess that's what I'm asking the folks to maybe potentially reconsider. Thank you very much.
Representative Leon and then Representative Weber.
Thank you. And McKay as well. Thank you, Mr. Chairman. In 2009, I broke my leg skydiving. I broke my femur, an uncomplicated, only a femur fracture. My first stop was at a hospital in New Hampshire, where they told me that I needed to consent for surgery the next morning. They couldn't tell me what procedure they were going to do. They wouldn't tell me what surgeon it was going to be. And they wouldn't let me wait until I met the surgeon because they were going to have to already be putting me under for the surgery before I had a chance to meet the surgeon. Now, I know a little bit about orthopedic surgery, and so I knew that depending on what kind of procedure I had was going to dictate the rest of my life, quite frankly, between limb length differences and everything else. I had enough knowledge to get myself out of that hospital and have myself filmed for a procedure for somebody who had invented one of the intramedullary nails. So not everybody gets that opportunity. I don't know if I'm the only person in the state who was told, you need to consent to this even though you don't know what the procedure is. That's what I was told. I was told that I was going to be denied care for at least a day if I didn't consent ahead of time. That shouldn't be happening. It shouldn't be happening. And it really should be simple to put this into statute so that hopefully that doesn't happen in the future.
Okay, Representative Weber defers to Representative Freitas. I'm sorry, Representative Freitas, I didn't see your hand up.
Thank you, Chairman, for letting me speak. I'm wondering in this, what is the patient responsibility? I have had several procedures done, one in which the office gave me a video to watch and watch the whole thing. And when I finished watching that, I thought, I don't think I want to do this. There were too many suggestions of what the results might be or whatever. Yesterday, I met with a physician's assistant, and I bet I talked to him about 20 minutes, new relationship, but there seemed to be an established relationship right away. So I guess we need to trust that our relationships are going to get us the information that we need and that we have access to information on our own. So I feel like this is
Inappropriate transfer.
Thank you. Representative Weber.
So my comment was just without wanting to stifle anybody's debate. I wonder if we could all consider among ourselves whether continuing to say what is basically the same things again and again is going to result in a change or not, or whether we should perhaps proceed to a vote. But I also saw, I believe I saw Representative McKay's hand, and he has not spoken yet. So
Sure.
I certainly, I just call upon your thought processes. It's lovely to debate each other, but if I thought things were changing, I would not have made the comment.
Representative McKay, would you like the last word?
Thank you, Mr. Chairman. I'll be very brief. I've been on this committee for a very long time. I've always opposed any legislation that prescribes practice of any kind licensed. I was a licensed clinical social worker. I don't want the legislature telling me if I was still in practice how to practice. But this, I don't see that this is necessary. I think if physicians already know what's best for the patient and are going to tell them what they need to know and not what they don't need to know. I've had some recent encounters with several doctors, and I was complaining to myself that why aren't they telling me what I need to know? Now I know why they didn't tell me what I needed to know, because now I know it and I can deal with it now. I couldn't have then. I think that physicians' practice is being invaded by this kind of legislation, and we've seen it over and over again over the years, and therefore I'm opposed to it.
Thank you. All right, Representative Tellez, unless it's something new, I'd like to move to the vote.
Yeah, thank you, Mr. Chair. A little bit new. I have spent over 20 years of my life trying to improve healthcare quality and access and making things better. I am a family doc. We very much value, and I think there are some differences by, specialty as far as temperament and personality and maybe bedside manner and how much time you spend with patients. But in general, I think we care fundamentally about patients, patient-centeredness, their autonomy, their ability to make decisions, and good docs currently who are trained now are trained to think of it as we're there to be almost like a coach, right? The decision is yours. We provide information. We support you. And even with that, appreciating that this is current, should be just the practice because it's the guidance. I agree with the point that was raised previously that there are some things in here that, for example, assessing patients' ability to understand. We are all of us, if you were all my patients, I'd have, 30 different experiences. We all have different levels of education. We have different levels of experience. 40% of the US population has low health literacy. That includes everybody, not just people who are very low educated. That means the ability to understand and use the information and the instructions resulting from a health encounter. Healthcare is complicated and complex. And so, ideally, physicians take all of that, especially since we're just pointing out physicians here, they take all of that into consideration, and we're conflating here what I think is bedside manner, patient education, and understanding of whatever the thing is, and then specifically informed consent, which tends to usually be more about procedures, a surgery, fixing my broken leg. And I think that is my concern, because you can't just standardize everything the same. Like, healthcare depends on continuity. Good healthcare depends on continuity, on relationship, on building the trust, the understanding, the sharing of information, and supporting patients to make their best decisions, their choices, not just telling them limited information. And so, again, I have a lot of concerns about just in general everything, the approach to legislating what is already good practice, as opposed to finding other ways to incentivize improvement in healthcare overall.
Thank you. All right, I'm seeing no other discussion, and we've had a pretty thorough one already. So I'll ask the clerk to call the roll. Motion is out to pass on HB 1280.
Representative Leon,
Yes.
Representative Cushman,
Yes.
Representative Bill King, yes. Representative Kofalt,
Yes.
Representative McLean,
Yes.
Representative Seth King,
Yes.
Representative Moffett,
Yes.
Representative Nagel. Representative Polozov,
Yes.
Representative Weber,
No.
Representative McKay,
No.
Representative Freitas,
No.
Representative Cannon,
No.
Representative Nutter Upham,
No.
Representative Shapiro,
No.
Representative Merchant,
No.
Representative Long,
No.
Representative Palmer,
No.
Representative Tellez,
No.
and Representative McDonald.
Yes.
10-10.
Okay, is there another motion? Representative Palmer.
I said it before, and I would move interim study because I think there is concern. My concern would be, how often is this happening? How much of a problem is it? And if it is a problem, then maybe we need to look at this more, but I would, that's what I would support.
You're moving interim study. Is there a second? Representative Nagel, seconds. Any discussion? Do you want to speak to that motion further, or are we all set? We've covered it pretty thoroughly, I think. All right, motion is interim study on HB 1280. Ask clerk to call the roll.
Representative Land,
No.
Representative Cushman,
No.
Representative Bill King, no. Representative Kofalt,
No.
Representative McLean,
No.
Representative Seth King,
No.
Representative Moffett,
No.
Representative Nagel,
Even though I seconded it, no.
Representative Pelosi,
No.
Representative Weber,
Yes.
Representative McKay,
Yeah.
Representative Freitas,
Yes.
Representative Cannon,
Yes.
Representative Nutter Upham,
Yes.
Representative Merchant,
Yes.
Representative Long.
Yes.
I missed you. Sorry. Representative Shapiro.
Yes.
I'm sorry. Representative Long.
Yes.
Representative Palmer.
Yes.
Representative Tejas.
Yes.
Representative McDonald.
No.
10-10.
Okay, that'll go to the House with no recommendation. We're not, we're on a roll here. Okay, moving on to HB 1300, relative to Terminal Patients' Rights to Try Act. Representative Merchant, did you have a motion? I believe there's an amendment.
Have an amendment.
Sure. We've got a bunch of Senate bills coming up. We won't be This is the last, these are the last House bills, yes. They all have to be done today. Yeah. Yeah, we because of the difficulty of these bills, we continued them as long as we could, but the deadline is now, so. Representative Merchant, did you want to make a motion about to pass on this, or?
I do, but given the fact it is a relatively long amendment, whether to delay discussion on this amendment until a little bit
We can
later,
go to
so
another
people
piece
go to
of-
another bill if we can, so people can digest it. I think
Sure.
it'd be helpful if we
can
have
do that.
time.
All right, so we'll take up 1300 later on. We'll leave it till the end if that works. How about HB 1585, Representative Weber? Did you want to talk about that one? Are you ready for that one?
Actually, I'm going to defer to Representative Merchant on that one. And I know that he has an amendment on that one as well, but it is a less onerous amendment. And I would also ask, Mr. Chairman, I noticed that the prime sponsor of House Bill 1300 is here. So I wonder if we could perhaps take that up after this one, so he doesn't have to sit here all day.
Okay.
But
We can be flexible on that. So Representative Merchant, when you come back.
And last night, the amendment on 1300 was emailed out to people.
Yeah,
but
it was,
pretty
it was
late.
sent to the committee. Yeah. Gary, the 1300 amendment was emailed out last night, just so you know, to the committee members.
Okay, so Representative Merchant, did you want to make a motion on the amendment for 1585?
I'll make a motion, ought to pass.
Okay, and just to clarify, this is, I know there's a number of amendments floating around on this.
It's amendment 2024 1246H.
1246H.
They went that way.
I'll second.
Okay, and Representative Leon seconds. Okay, Representative Merchant, would you like to speak to your motion?
Thank you, Mr. Chair. The critical piece that was changed, it's more for clarification than anything else. After working with Representative Groder and other folks, I think this is a little more clarity to it. If you look on page 2 on lines 3 through 6, what I'm trying to get to now is that many of the injectables come in what they call self-administered auto injectors, pen injectors, things to do with insulin and so forth, etc. So the intent is to be sure that we're not drawing from a vial, but the device that's being utilized is actually filled by the manufacturer, not somebody else. So it's a safeguard. It's really trying to be sure that you're in a residential care facility, you have somebody's being trained, but when you get into injectable medications, my concern is that that's where a lot of mistakes can happen. So to minimize that possibility by having something that's pre-filled, it's a self-injector, you basically can help the patient put the pen to the body, if you will, push the button, basically an auto-injector. So what this bill amendment does to the bill under 3 through 6, and also under lines 35 through 37, is to clarify that. So that's all it's doing. It's just being very clear. We're talking about auto-injectors and not talking about something else.
Representative Land, did you want to speak to your second, or?
No, I think we've discussed it pretty well.
Okay, Representative Shapiro and then Representative Tellez.
I just have a quick question. I have 3 amendments from the original bill, or at least I have part of one and 2 full ones. So is the suggestion to adopt all 3 amendments, or 2 of them,
No.
or just
Just
the last one?
1246H.
Just the last one. Okay,
For
Thank you.
clarification, Mr.
Yes,
Chair.
Representative Weber?
They're all amendments in the entirety. They have little tweaks, and so there's no need to adopt more than one. And I will
thank you.
let Representative Merchant go on speaking because
Representative Tellez had her
Yeah.
hand up.
Thank you. I just had a question. So I listened to the prior hearing and heard the discussion about the why we don't want the Kalamas drawing up their own meds. But what about, or are there ever instances where maybe a pharmacist or a appropriately licensed level nurse could be filling a syringe with a correct amount of medicine and leaving it to be administered by the Kalama?
It's possible, although the way the bill is written, all the amendments so far, if it's drawn from a vial, that's prohibited. So whether the pharmacist does it, whether somebody else does it and gives it to the calmer, that would, in my opinion, not be permissible.
I mean, I know that's how it's written, but that's why I'm asking, would we want to allow it? If you had the appropriately credentialed, an experienced person doing it correctly, but leaving it so the person could administer it? Should we allow that?
Representative Weber, did you have something to add to this or clarify? Or?
I would only comment that this bill has been the subject of
Yeah.
about 6 months worth of meetings. And what you are discussing is something that a level of discomfort was expressed consistently throughout those meetings for multiple parties. So while it might be okay, my sincere hope is that this bill now represents what all of these people are comfortable with. And yes, there may be things in the future that we need to add, but my sincere hope is that members of this committee would agree on this amendment, which is the best that has come up yet. Move things forward, recognizing that there will be more discussion in a place I cannot mention, but mention anyway, and further discussion under rulemaking, which is now included specifically in this amendment. And so this gets us further forward. And I don't want to let the perfect for one be the enemy of the good for all.
I get it. Thank you.
Other discussion? Representative Shapiro.
I just want to say quickly that probably a year ago, Representative Weber and myself got an email or a call from our county nursing home administrator suggesting a bill like this. And it ends up, it didn't even apply to nursing homes, but it's been a long, circuitous journey. And I give a tremendous amount of credit to all the people who've worked on it. And I think we've come up with something good and that we can feel really good about. Thank you.
Thank you. Other discussion? Seeing none, I'll ask the clerk to call the roll. Motion is ought to pass on amendment 1246H to HB 1585.
Representative Leon,
Yes.
Representative Cushman,
Yes.
Representative Bill King, yes. Representative Kofalt,
Yes.
Representative McLean,
Yes.
Representative Seth King,
Yes.
Representative Moffett,
Yes.
Representative Nagel.
Yes.
Representative Pelosi,
Yes.
Representative Weber,
Yes.
Representative McKay,
Yes.
Representative Freitas,
Yes.
Representative Cannon,
Yes.
Representative Nutter Upham.
Yes.
Representative Shapiro,
Yes.
Representative Merchant,
Yes.
Representative Long,
Yes.
Representative Palmer,
Yes.
Representative Tejas,
Yes.
and Representative McDonald,
Yes.
20-0.
Okay, do I have another motion?
Motion ought to pass as amended.
Representative Nagel seconds. Any further discussion on this? Seeing none, the clerk is ready. Motion is ought to pass as amended on HB 1585.
Representative Leon,
Yes.
Representative Cushman,
Yes.
Representative Bill King, yes. Representative Kofalt,
Yes.
Representative McLean,
Yes.
Representative Seth King,
Yes.
Representative Moffett,
Yes.
Representative Nagel,
Yes.
Representative Pelosi,
Yes.
Representative Weber,
Yes.
Representative McKay,
Yes.
Representative Freitas,
Yes.
Representative Cannon,
Yes.
Representative Nutter Upham,
Yes.
Representative Shapiro,
Yes.
Representative Merchant,
Yes.
Representative Long,
Yes.
Representative Palmer,
Yes.
Representative Tejas,
Yes.
and Representative McDonald,
Yes.
20-0.
And the committee report will be sent shortly.
Okay, thank you. And if there's no objection, consent. Okay, are we able to go back to 1300? I know it's detailed, but also again, we've got the prime sponsor here. Representative Merchant, do you think we are ready?
I think so.
Okay, great.
I just got to put myself here. So it's going to.
So you have an amendment 1223H.
Okay, just trying to get myself organized here. Yeah, I've lost. If I may just have a second to get myself organized.
Sure,
Thank you.
sure.
Is there a second?
Nagel. Ms. Swin.
If I may.
Sure, go ahead.
Thank you, Mr. Chair. So,
Did you want to make a motion about to pass on your amendment?
correct, to pass as, on the amendment, yes, please.
1223H, is there a second?
1223H.
Nagel seconds, Representative Nagel seconds. Go ahead, Representative Merchant.
Thank you, Mr. Chair. This came to us from a fellow representative, and the intent of the bill is that there are times in which a patient may not be able to get into a clinical trial or be able to utilize certain things that are out in the marketplace, whether it be a biologic, a drug, a device, and so forth, under compassionate use. So this is really modeled more after the federal law to allow it also to occur within the state law. So it does two things. One is it allows the opportunity for patients, with the advice of the physician, to utilize things that may not be in the normal course, compassionate use and so forth. And number two, given the fact that this is going into that arena, it provides a certain level of protection to the provider. So therefore, the provider, if they're willing to work with the patient on this and they're agreeable to it, we're trying to provide some level of protection to the provider. We're going into uncharted waters that haven't been fully vetted, if you will, through scientific studies and evidence and so forth. But there's a intent by the patient who's been informed that this is a possibility to help you. To give you an example of something, I have a dear friend who actually has gone to Japan and has spent several thousands of dollars because the treatment that they can get in Japan is not available here in the United States. That's an example, and he's actually trying to work with people federally to modify certain things to allow for more of this to occur. So all this bill fundamentally does is allow that opportunity for a patient who's been informed, has full consent, and also to provide some level of protection to the provider from liability. And I want to say thank you to both Representative Leon and Representative Nagel, who, and actually most of this goes to Representative Leon, so I want to say thank you for a lot of the work you put into it and making this possible to bring forward.
Representative Leon.
Thank you, Mr. Chairman, and thank you very much, Representative Merchant, for all the hard work you put in it as well, and Representative Nagel. So our terminal patient right to try law was passed in 2016, and that was before the federal right to try was passed. Over time, it's moved from sort of more the compassionate use to more and more following along the right to try pathway, and our existing law is in conflict in some areas with the federal law. Any of these manufacturers of drugs, biologics, or devices are worried first about whether or not the FDA is going to allow them to continue making their products available. So that will always be the first thing that they look to. Our statutes, because they were in conflict, may have been one of the reasons why it was hard to access this. I do know that when people that I know that were trying to place compassionate use, they ended up placing it into offices and into facilities in Massachusetts as opposed to in New Hampshire when the person was able to practice in both. I don't know if it was because of the laws around the right to try or because those institutions were just a little bit more accepting of having these. Quite frankly, one of them, so the person had to go halfway across the country as well. So this, by standardizing it and making sure that our terms are consistent with what is now federal law, is a good way to provide this access. It does change it from terminal to life-threatening disease because when it was first passed, none of this was done on the federal level, and everybody was trying to move that momentum towards it. The life-threatening disease is a disease or condition where likelihood of death is high unless the course of disease is interrupted, or those with potentially fatal outcomes where the endpoint of the clinical trial that they used to study it was survival. So you're talking about that. That's just a more elegant way, I believe, of saying terminal. And it also points back because we want to make sure that as we focus on this right to try this this compassionate use, we're also not pretty much crowding out expanded use, because the manufacturers can provide expanded use as well, which is where the physician requests access to an investigational drug, device, or biologic, and that one's done by an institutional review board that otherwise would not be underneath these statutes because it's a whole different process. And this also points to the off-label use, because if it's available on the market, The doctors are already protected from licensing penalties simply because it's off-label. We passed that 2 years ago. And I want to thank the sponsor for bringing this because it was a harder lift than any of us thought, but I think this actually is a really nice solution.
Representative Merchant.
And thank you, Mr. Chair. Following up on Representative Leon, I was initially opposed to changing the word terminal to life-threatening. But given the fact that so much has been developed in the markets, if you will, with drug therapy specifically, that even cancer today is turning into a chronic disease. So it's not terminal. Actually, any disease is terminal ultimately, but it's life-threatening. So therefore, you want to change the word from terminal to life-threatening to allow for that broader interpretation of the law.
Representative Nagel.
Thank you, Mr. Chairman. I just wanted to again thank the sponsor. It was really great that you brought this is a really important issue. As of Friday, we were in a quandary and we had basically were going to interim study. And we felt horrible about that, but we felt there were so many problems with this language. And personally, every one of us has a terminal illness. It's called life. So I've really struggled with that whole. I looked through definitions all over the place and I didn't really like any of them. And I think that was a brilliant way to look at it as life-threatening as opposed to that. And Representative Leon basically put everything we were talking about on paper and you saved the day. And that was awesome. And I think we have a good bill now.
Representative Weber and then Representative Palmer.
Thank you, Mr. Chairman, and thank you all for your work on this. I too was one of the ones who came to it saying, and this is one where, like the previous bill, a lot of talking has persuaded me that the guardrails that are in this bill and the parameters that are expressed in it are good ones, and that I'm so pleased that we're able to come to a place where I can say, yeah, we really ought to be doing this. And it's taken me a while to get here, but I appreciate all of those who kept talking and kept working because it's a much better place to be in.
Representative Palmer and then Representative McLean.
So last night we were talking about this, and I initially had significant reservations, and then as we were talking, I remembered the AIDS epidemic and compassionate use of AZT, and then my grandfather getting Coumadin from France in the 1950s for a blood clotting disorder that, and I might not have ever gotten to know him if it weren't for these sort of sneaky ways in of getting treatment. So I'm now happy.
Representative McLean.
Thank you, Mr. Chair. I believe in the importance of right to try, but the one question I have, and you probably already covered it, but it was a lot for me to digest, is what does this legislation do for us beyond the federal legislation? And I know there was a lot was kind of thrown at me just a couple minutes ago, but could you just kind of condense what does this do beyond the federal right to try?
Representative Merchant and then Representative Leon.
Part of it that, as Representative Leon said, there was conflict between the federal. So the state law can be more restrictive than federal law, but it can be more lenient. So if we don't remove some of the restrictions we have in a state law to allow for more use at the federal level, that's what the bill's trying to do, is allow for the state law to be in concert with the federal law to provide more accessibility. Because the way the current law is written, it's more restrictive than the federal law.
Representative Leon, did you want to add something to that?
If Representative McLean has another question, I
Yeah,
can see
just quickly. So so now from a restriction level, we're at par. So there's no, okay.
And further, what this does is it protects those providers who are doing this from any adverse things from the licensing board for doing this. So because they're regulated by the state licensing board, we need to make it clear that the state licensing board won't come after them if they're doing this the appropriate way. And just some of this other language, it was just confusing and conflicting. And my husband's helped place compassionate use of drugs and to have right to try, that sort of thing. And the way that our statute was written was just really, really cumbersome, and legal departments just weren't comfortable with it. So now by removing those restrictions, we have that, but we do need to have those protections in place against the licensing penalties. So that's why it's important for us to have it in there.
Well, thank you very much for the answer and all the good work on this. Thank you.
Representative Shapiro.
Thank you, Mr. Chairman. In reflecting about this bill, I'm kind of thinking about all the debates and conversations we've had about limiting what people can do over the years in this committee. And so it's really refreshing to have a bill that's kind of expanding what people can do. And all of us have had people close to us who've been in situations where this might come in really handy. And so I'm really glad to support this bill.
Representative Leon.
Thank you. And I want to thank Representative Shapiro and everybody who was here 2 years ago, because we did, and we expanded access for FDA approved drugs, devices, and biologics through our off-label. So we had already done
Right.
that there. And if it wasn't for Representative Lewicki bringing this to us, we wouldn't have realized the conflict in the statute. So yes, we sometimes see the airtime of the other stuff, but we do good stuff in this committee.
Other discussion? Seeing none, I'll ask the clerk to call the roll. The motion is ought to pass on Amendment 1223H to HB 1300.
Representative Land,
Yes.
Representative Cushman,
Yes.
Representative Bill King, yes. Representative Kofal,
Yes.
Representative McLean,
Yes.
Representative Seth King,
Yes.
Representative Moffett,
Yes.
Representative Nagel.
Yes.
Representative Pelosi,
Yes.
Representative Weber,
Yes.
Representative McKay,
Yes.
Representative Freitas,
Yes.
Representative Cannon,
Yes.
Representative Nutter Upham,
Yes.
Representative Shapiro,
Yes.
Representative Merchant,
Yes.
Representative Long,
Yes.
Representative Palmer,
Yes.
Representative Tejas,
Yes.
and Representative McDonald,
Yes.
20-0.
And if there is no objection, we'll put
No,
that on the
it-
consent.
We have to.
Ought to pass. I'll
Oh,
make a
I'm
motion,
sorry.
ought to
I
pass
always
as
do
amended.
that, don't I?
One more.
All right, do I have another motion?
Motion ought to pass as amended.
Okay, is there a second? Representative Nagel, seconds. Okay, any other discussion? Seeing none? Okay, when the clerk is ready, we will, motion will be ought to pass as amended on HB 1300.
Representative Land,
Yes.
Representative Cushman,
Yes.
Representative Kofal,
Yes.
Representative Bill King, yes. Representative Kofal, yes. Representative McLean,
Yes.
Representative Seth King,
Yes.
Representative Moffett,
Yes.
Representative Nagel, Representative Pelosi,
Yes.
Representative Weber,
Yes.
Representative McKay,
Yes.
Representative Freitas,
Yes.
Representative Cannon,
Yes.
Representative Nutter Upham,
Yes.
Representative Shapiro,
Yes.
Representative Merchant,
Yes.
Representative Long,
Yes.
Representative Palmer,
Yes.
Representative Tejas,
Yes.
and Representative McDonald,
Yes.
20-0. Now,
Now, consent if no objection.
No objection.
Okay,
And I'll get the report to the chair.
great, thank you. So you have that one, Representative Merchant, you have one other one, right?
Yes.
I have two. I have
1585.
Right. Okay, next up, we're ready to discuss 1607.
Yes, and I have an amendment.
Okay,
Mr. Chair,
yes, I heard a voice. Now, Representative Lewicki. Absolutely. Okay, thank you, and thank you for introducing it.
Thank you for
Thank you
bringing
for
us
being
the
here.
bill.
Thank you.
Yeah, I know it's confusing because it's easy to confuse those two, especially where they're right
I
next to
sent in
each
an amendment request with the numbers transposed.
Do we have one amendment, Representative Merchant, or two?
One,
What's that?
We'll start with this.
one.
Oh, just one, so it's,
One-
1220 is the only one.
We'll see, yeah. this
Well,
one was-
12
No, yeah, 1220.
2024 1220 H is the one I'm
Okay.
bringing to the committee.
It's coming
Yes,
around.
It's coming around. Any more copies on that side?
I have extra copies if you need.
So I'll make a motion on House Amendment to House Bill 1607. It would be Amendment 2024-1220H. And I'd make a motion to
Okay,
authorize.
Representative Kofal seconds.
Yes.
Hey, would you like to speak to your motion?
Yes, I would. Thank you, Mr. Chair. I had a very long conversation with Representative Cadelli, myself, Representative Major, also Representative Seth King. We had a call, and based upon that, try to come up with language that we could sort of thread the needle. And the discussion was how thick the thread was or how wide the needle was. But we found something to settle on. In further discussion, I found that there could be some other situations. So I support the amendment, but I may, depending upon the discussion at the bill level as amended, may ultimately change my mind. I talked to Representative Cadelli about this. But the fundamental thing we're trying to do, I think the intent of it is that when a child is born and the parent, particularly the mother, feels that they don't have the resources or the temperament, whatever the reason they are, they want to have the child taken care of by somebody else, that they have a safe place to do it. Historically, it's always been through a handoff, a warm handoff. Part of it, though, is trying to protect and make this as anonymous as possible. The baby box does that, so the parent doesn't actually have to engage with another human being, which gives up their anonymity, which is concerning. So in essence, with the baby box, it does allow for the child to be placed somewhere safe in a sort of an incubator that is monitored 24/7. So the intent of this was to basically say that if you do, as a parent, place the child into the baby box, that you will have a certain level of immunity from criminal prosecution. And part of that is you don't want to have the mother being torn between, do I give up my child, or do I try to face the possibility of some sort of criminal prosecution for whatever reason? So this was a way to try to minimize that tension between the two and say at this point in time, if you're willing to give up the child, then at that point in time, there's a certain level of protection for you. So that's what this amendment does. It doesn't make it 100% exclusive. I'm not an attorney. I wish I was at times, but well, it would help a lot of times. I think a lot of things we get into, the legalese part of it is that, look at Representative Weber. It's a tough, when you're trying to write a law, to understand what the terminology is. A lot of it comes into legalese, if you will, and I'm not really trained in that arena, so that's put me at a disadvantage. But anyways, that's what I'm trying to put forth with the committee. I do ask the committee to support the amendment. I may not support the bill as amended, but I will like the committee to at least support the amendment.
Representative Weber and then Representative Shapiro.
As one who went to law school and was told that every word in every statute was a pearl polished to perfection by legislators, coming here was a shock. But even before I came to the legislature, I was a fan of people writing in English that could be understood by people who did not have law degrees, and I'm all for it. I think with respect to the language of this amendment, it does make the bill better, and I'm going to vote for the amendment because it does not address all the concerns that I have that arise from the extension of the period of time to 60 days, which is a long period of time, if a child is being abused, neglected, or in some cases beaten. I don't want to get us to a point where that child is put comatose in a baby box and there are no consequences. I think all of this is pretty attenuated logic, but for various reasons that I'll get to when we get to the underlying bill, I'm not in favor of the bill. I very much applaud the intent, but I don't think it's going to do what people want it to do. But I will vote for this amendment because I think it makes the language marginally better, and then we can go on from there.
Representative Shapiro.
Okay, thank you, Mr. Chairman. All this talk about lawyers and polished pearls, and so I still don't understand what this amendment says. Like others have said, I have questions about the underlying bill as well. But I really applaud all the people who worked on trying to parse this exclusionary area of the bill. It's kind of like a moral dilemma that there's no good answer to. So I give people Representative King for starting us off on exploring how to solve such a difficult dilemma. But now that we have a solution, I don't fully understand it. So if there is somebody who could tell me, does this mean that that evidence was gathered through this process cannot be grounds for charges of abuse and neglect? Well, then it says, or criminal prosecution. So what can it be used to charge someone with?
Representative Weber.
Well, first of all, I was never a criminal attorney. I was an elder law attorney. So I think there have been a number of misunderstandings. First of all, it was written in the original bill as an exclusionary rule. You cannot use it at all. And this has at least moved us in the direction that it might be used. What I'm concerned about with the way the bill is written now, I think it still means that a parent who may have been abusive to a child over a significant period of time, as long as 2 months, may escape prosecution because it says here, as a direct result of a parent acting in accordance with this chapter. And to me, and this is just me, and I'm not giving a legal opinion, I'm giving a plain English opinion. As a direct result means you wouldn't have known about this except that somebody surrendered that child. And I think all of us are very much in favor of allowing parents to surrender a child if they are convinced that they are unable to raise the child. We want the child to have the best opportunity at life. But I also don't think that this language allows the deterrent effect that I think we need if, in fact, I just see the one horrendous case coming down the road. And nobody knew about this child, nobody reported this child, so it isn't like, I think in this case, if say the neighbors had already called DCYF and said, really concerned about the kid down the street, and then the child was surrendered, you still have the neighbors and them talking about their concerns, because that's not a direct result of the surrender. But if nobody had ever said anything about this particular child and their fears for this child, and the child arrived very heavily abused, clearly voluntarily abused, or severely neglected, either one, I think that this means that that's the end of the story, and I'm not comfortable with that. And it's one of the reasons why I'm not comfortable with going from 5 days to 60 days. So, but that's not what we're talking about in the amendment. So other people may have other interpretations because it doesn't matter how much we polish the pearls, people see them differently. That's mine. That's my concern.
Representative Kofalt and then Representative Leon.
Thank you, Mr. Chairman. So I think my reading of it, my interpretation of the language actually does fall on the other side of the center line, I guess. The way I read this, it says that any evidence obtained as a direct result of a parent dropping off their child shall not be grounds. And to me, that suggests that there may still be an investigation and other grounds may be determined sufficient. I believe that in the vast majority of cases where a child is dropped off and it seems very, very clear that there has been abuse, it is likely that an investigation would ensue if possible. That leaves me concerned that this is not sufficiently removing the disincentive to drop off the child. Having said that, I do know that a lot of work went into this, and I know that legal counsel was closely involved in the process of drafting this language. So I will be voting for the amendment, but I guess I just wanted to offer that alternate interpretation.
Representative Leon.
Thank you, Mr. Chairman. I think this really is about all of those hard cases. You have an infant and the parent strikes them and they're in the car. And what do? They go to the hospital. Maybe that parent's not going to do that. Do they kill the child? Or do they go to a safe drop off and say, I lost my cool. I can't do this. I'm giving this baby up because I just did this and I can't trust myself. It's a horrible thing to have to think about. But our question is, do we want to make it so that child has a chance to live because the parent's able to drop them off? At this point, I fall on the side of giving that protection because I am more important in that more concerned about that child and that child's life than I am about that prosecution, because that's what it comes down to. And I want to save that life. There's so many of these other externalities that I wish we could control for. But if we could legislate about that, or if we could fix that, we wouldn't have to worry about these situations. You know, it's really a hard challenge, and I understand why people fall on both sides of this, but I think it's more important that a parent can say, what have I done, and relinquish the child and save that child's life.
Other discussion? Seeing no other discussion, I'll ask the clerk to call the roll. The motion is out to pass on Amendment 1220H to HB 1607.
Representative Leon,
Yes.
Representative Cushman,
Yes.
Representative Bill King, yes. Representative Kofalt,
Yes.
Representative McLean,
Yes.
Representative Seth King,
Yes.
Representative Moffett,
Yes.
Representative Nagel,
Yes.
Representative Polozov,
Yes.
Representative Weber,
Yes.
Representative McKay,
Yes.
Representative Freitas,
Yes.
Representative Cannon,
Yes.
Representative Nutter Upham.
Yes.
Representative Shapiro,
Yes.
Representative Merchant,
Yes.
Representative Long,
Yes.
Representative Palmer,
Yes.
Representative Tejas,
Yes.
and Representative McDonald,
Yes.
20-0.
Okay, do I have another motion? Somebody else want to make a motion? About to pass as amended, I assume. Representative Kofalt.
Yes, I move OTPA on House Bill 1607 with Amendment 2024-1220H.
Is there a second?
Second.
Representative Leon seconds. Would you like to speak to your motion? Or?
Yeah, I think I'll keep it brief because I think we've said it all before. This bill is intended to save lives. I think there are a number of thorny issues that emerge. I don't think that we can solve all of them, but I think we can take our existing law and move the ball forward and potentially save more lives in the process. So I urge my colleagues to vote yes on this motion.
Representative Weber.
And while I have exactly the same objective, which is saving more lives, I truly believe we got it right when we passed the safe haven law that we passed. I feel that having the short period of time and a warm handoff is just something I in my gut feel more comfortable with, and I cannot give it an intellectual explanation, but that's what I feel comfortable with. And this bill, as it has been brought to us, I don't feel comfortable with. I'm concerned about the longer period of time. I'm concerned about the fact that I don't believe that anybody who is truly disorganized and unable to control their behavior and is truly desperate is going to be organized enough to find the place, get to the place, and do all of that. And I just think we got it right the first time, and so that's why I will be voting no, but I do recognize and applaud the work, the concern, and the effort that goes into this, because we all want babies to be raised in safe, caring, loving environments. So.
Representative Leon.
Thank you, Mr. Chairman. I recognize the concern around shortening the time period, but we also need to think about some of the babies that are born. They're a little medically complex, and it takes over a week for the mom and baby to be discharged from the hospital. With that, if they get home and 2 or 3 days into it, they just realize that the supports they thought they were going to have aren't there, and they hit that crisis point. You know, why are we going to say that some people get to have a few days at home before they have this opportunity versus other people who have a longer stay don't have it? You know, it's one of those areas, it's challenging, because I do agree that 2 months does open up a larger window, but honestly, that first week doesn't seem to be with the new moms that I've spoken with. That's not really where the dip hits when you're going through that, because you're still on the adrenaline. You still have people showing up to help if you have a support network. But if your support network is fleeting and they're gone 2 weeks into it, that's where you may actually be hitting more of your crisis mode. And that's where it actually becomes a little bit more important for to have some of this access. And I know that there's some concern around the boxes themselves too, but just because I worked in medical devices, these aren't medical devices, so it's not limited to just any certain approved design. Obviously, that's one where anybody who's doing one of these baby boxes would make sure that what they're doing meets the intent and the requirements of it. But, it's not like we're creating any sort of monopoly. I mean, catch me later at 1 o'clock. I'm fighting the monopolies. I'm fighting against that whole sort of model. So hopefully you understand that I see this as an opportunity, not just to have one type of baby box, but to have this as an opportunity, because some people are just so incredibly ashamed to say that they can't take care of their kids, and to face another human. They'd rather not exist than face another human and say that they failed their child. And do we really want that parent and that kid in a situation where they'd rather not exist than have to admit that they failed? And I think this baby box gives a way to save those lives and allow them to make a better, safer choice and move past it.
Representative Cannon, and then Representative Kofalt, and then Representative Merchant.
I haven't spoken up a lot about this particular bill, but I am a co-sponsor, and I value the life of a child. And my intent when I was asked to co-sponsor this was, will it save the life of one more child? um, I recognize that there's some potential problems with the bill as it stands. But that's a fairly complex topic. As do we cover all of the aspects of it? My gut feel is that it would be much better to pass this and get something put into place. And if there's a problem that maybe the state needs to revisit and iron out what the problems are with this. But if it saves the life of a child, I think it's the right thing to do, and I would vote for it.
Thank you. Representative Kofal.
Thank you, Mr. Chairman. So just as a point of reference, looking at other states in New England and the time frame that they allow, Connecticut is 30 days, Maine is 31 days, Massachusetts is 7, New Hampshire is 7, Rhode Island is 30 days, Vermont is 30 days. So that's just a point of reference that I think a number of others have deemed that to be a very reasonable time frame. I think many of them for the reasons that Representative Leon outlined. And, you know, it may be that the other body wants to cut this back to 30 days, but 30 days certainly I think is absolutely reasonable and does have the potential to save more lives.
Representative Merchant and then Representative Freitas.
Thank you, Mr. Chair. I wanted to thank you to Representative Cordelli, who's in the audience, for working and trying to find a way to thread the needle. Sometimes it's a little more challenging than others. This is one of those challenging times. I went back and did some research, and one of the things that came out of the Yale School of Law and Medicine is the issue of restricting it to a parent, particularly to a mother, was problematic. And what it really comes down to is that sometimes you have mothers who live in areas that are rural, they don't have transportation, they don't have the way to get to a baby box. Number two, you have mothers who probably don't have the wherewithal, if you will, to take advantage of the law. And therefore, you have to rely upon somebody else to bring the child to a baby box or to a safe haven. This law does not allow for that. It only allows for the parent. And I do understand the other side of the issue, that you could have somebody as a grandparent that could kidnap the child, if you will. But I think we need to be sure that if we're really talking about the child and protecting the child, that we have multiple ways to get the child to a baby box, not limited only to the mother or to the parent. The other issue I have is what I call gross physical abuse, or gross neglect, which is different than abuse or neglect. Again, those terms are back to the legalese, I think, defined when you talk about gross abuse. If you have a child who has been grossly abused, and when you go from 5 days to 60 days, that's a long time to abuse a child. And sometimes you get to the point where you're at the end of the rope and you really have a child that has been abused to a point where it's almost non-reversible. You could have a child with shaking the child, and that's been shown again with a person who takes a child and shakes them because they just are so frustrated with the child. Is the trauma in the brain is phenomenal. So what I'm trying to be sure of is that if that is occurring at that point in time, whoever is doing that, we're not protecting it. Now, the way this is done with the parent, if the parent's doing it, they get a get out of jail free card. If it's somebody else, not the parent, which is the good thing about limiting it to the parent, then they don't. So I'm trying to look at this and saying, how do we protect the child? Not just to have the child come to a safe haven, but the journey from birth to the safe haven, that they don't come to the safe haven in such a way that they really are still alive, but they're not going to be able to really live. And that's what I struggle with. That's the quandary I'm in. So therefore, I think the 60 days is problematic because of that. 30 days would be better. The shorter the window, I think, is better. But right now, we don't have language in there talking about gross abuse or gross neglect. So therefore, I would not be able to support the bill.
Representative Freitas and then Representative Seth King.
Thank you, Mr. Chair. My thought is about the warm handoff. The fact that you're putting this baby in a box, like mailing a letter. What about the mother? Is there any intervention for the mother? For any intervention for the future of the child? So I would, for voting ITL, that we would drop the baby in the box. Thank you.
Representative Seth King and then Representative Shapiro.
Thank you, Mr. Chair. I've already spoken a lot about this bill the first day we looked at it. So I will try not to repeat myself, but I spoke with a representative from Cornerstone after that day, and I came to the conclusion that, you know, my original amendment, which was going to scrap the exclusionary clause altogether, that was also faulty because, and I understand now that, you know, if we're prosecuting people for what I would consider victimless crimes, as a result of this, then what's going to end up happening is that there will be too many people that would be afraid to use the baby boxes. It would get a bad rap and then they wouldn't get used. And I understand that completely. So my original amendment of just getting rid of it was too far. However, my original concerns, which was just articulated by Representative Merchant, remain, which is the idea of not just, you know, a poor parent, but somebody who really intentionally abuses children. And the idea of protecting that is not something I can support under any circumstances still. I was hopeful that this amendment, which I did vote for because I do think that the bill should be presented as intended by the author and such, but the amendment, it does not thread the needle, and it doesn't, you know, ideally what it would do is it would let people, so to speak, off the hook for, you know, drug crimes. But people who really intentionally abuse children, they would not be off the hook. And so I went home as I was driving home the other day thinking about it. I couldn't quite wrap my head around why it just felt so wrong to me, the idea of letting somebody off the hook. And, you know, we often hear it's better to have an alive baby than a dead baby, and I can understand that completely. However, that's not actually how we act in society. So, for example, if somebody were to kidnap a child and they had that child for a couple of months, would the law enforcement come out and give a clarion call to the entire state and say, look, if you just bring back the baby, there will be no prosecution whatsoever? Would we do that? No, we would not do that. And you might be able to say, well, maybe we should just let the kidnapper off the hook because it's better to have an alive baby than a dead baby. Never mind the fact that who knows what they've done to that baby in the last couple months. So we don't do that, nor should we. And it also is kind of along the lines of like, you know, hostages. We don't negotiate with terrorists because the moment you do that, yes, you might save the life of that one hostage, but then you're going to send that clarion call out to every other opportunist who will now say, hey, look, all I have to do is kidnap somebody. They'll give me the $1 million and let me go scot-free. Therefore, let's start doing that. And my concern is that when we let people who abuse children off the hook, we are opening up Pandora's box to let all of the would-be opportunists take advantage of this. There was an article in the news just the other day. Some lady was pimping out her newborn child to sexual predators. So this is something that really does happen. And my fear is that if we put something like this into law, we're basically saying you can do whatever you want to a child for 61 days as long as you bring it back, no questions asked. And I can't go with that. I think we need to send a strong signal that if you abuse children, we will come after you, we will prosecute you under the fullest extent of the law. Zero tolerance for people who abuse children, period. So that's why I can't support this. Thank you.
Thank you. Representative Shapiro.
Thank you, Mr. Chairman. So I've gone from agreeing with Representative King's feelings about accountability when he first brought it up so eloquently to today agreeing with Representative Kofolt's statement about the immunity not going far enough. And so I realize how difficult an issue that is, and I've been all over the map. But my concerns at this point with the bill are other than that, which are I'm uncomfortable with this being written for safe haven baby boxes, which are essentially, you know, a specific company. And I've talked to Representative Cordelli about that, and he suggested that there are other possibilities to look into, which I think is a good thing. So I'm uncomfortable with it being written for a particular company. I'm really uncomfortable with the whole idea of putting children in a box. I think the significance of anonymity is probably a little overblown here, and that you know, things go wrong. I mean, we have scientists and computer scientists who will develop these boxes in a way to make them as safe as possible, but nobody expected COVID. You know, nobody expected some of the, you know, dramatic things that have happened, like nuclear meltdowns. We just don't have control over, technology doesn't give us the control that we think it has. So I am much more comfortable with someone handing off a child to a live person. I do think that extending the time to 30 days or even 60 days is a good idea. I think we should keep in mind that this isn't the only way that people can come to terms with not being able to take care of their child and getting help, including putting their, you know, terminating their own parental rights and creating the opportunity for other parents to take care of this baby. This law is not the only way that that happens. That happens with people coming to DCYF or coming to the attention of DCYF, getting involved with DCYF and saying that they, you know, they're really not capable of taking care of a child. And child goes into foster home and is eventually adopted. So we shouldn't think that this is the only mechanism for someone coming to their senses that they're not able to be the parent for a child. There are other options as well. So for all those reasons, plus the fact that when we were trying to interpret what we wrote as in the new amendment, we all agreed that we weren't sure what it meant. So I'm not really comfortable with passing I think this is well intended. I don't think it's ready for us to pass. So I'm going to vote against it.
Okay. Representative Leon.
Thank you, Mr. Chairman, and thank you. I wanted to note that this is not set for any particular company's boxes.
If I may, Mr. Chair,
Representative Merchant.
I just checked on that because I was concerned about that too, but that is a patented name.
It's a patented name.
Yes, ma'am.
Representative McKay and then Representative Cushman.
Thank you, Mr. Chairman. 20 years ago is the first time I remember this legislation coming before us. So it's pretty remarkable that 20 years later it's still here, which to me means there is a tremendous need for this kind of legislation. And it's difficult to get at. Somebody talked about the symbolism of a box, and it certainly reminded me of a coffin. And we can't be driven off the track by being concerned about those kinds of things. I think there's a great need in addition to what is available to protect these children, this is the first opportunity I think we've had since 20 years ago to do that, and therefore I'm going to vote yes.
Thank you. Representative Cushman.
Thank you, Mr. Chairman. Well, my suggestion, I'm not sure if having the name, even though it is a patented name, we're not using it to sell a different product or something like that. It's also a descriptive name, and not necessarily used in that manner. But I don't know how those kind of laws work with us having this in statute. But my suggestion is that we, if this gets through this committee and then through the House, that we ask the other body to maybe change that name once it gets there.
Mr. Chair.
Representative
If I could
Merchant.
respond to Representative Cushman. I concur what you're saying, but there's certain words that we use like Kleenex, Formica, that are patented names. And therefore, if we refer to it that way, we're in essence, which is my concern here, as a state, we're endorsing a particular manufacturer of a product and not allowing the free market to do what it's supposed to do if somebody else wants to come back into the market and compete against it.
Representative Kofalt, and then Representative Nagel. I don't know. Okay, all right.
Thank you, Mr. Chairman. So my intent in supporting this and my understanding of this is that it is not endorsing the use of one company's product in particular. So to the extent that that is, helpful to anybody who may want to interpret this in the future, that is my intention. My understanding is that there's currently one company that makes these boxes, but that there are private charitable concerns that have come up with designs and are building these boxes in some other states. So I think that there are, I believe, 3 designs out there, one of which is the Safe Haven box referred to here.
Representative Nagel, and then Representative Leon.
I guess since I researched it, I wanted to bring it up, but I really didn't understand the 60-day thing, where that number came from, if there was any scientific evidence. I have a graph with all 650 states and what their rules are. 60 would definitely be an outlier. The mode is 30. Most of the states are in the 28 to 31 day range. One's 364 days, so if you pick 60, that's an extreme, obviously. North Dakota. But there's only a handful that are over 30. So I mean, again, I don't, you guys know process better than me. The Senate can certainly change that. I just don't know how you feel about that. Oh, the other body, sorry.
Representative Leon, then Representative Weber.
Thank you, Mr. Chairman. I think through all of our discussion in committee, it's been very clear that we aren't looking to endorse any specific manufacturer. I think that that's something that easily we can ask to change. And I think the other body knows how I feel about the government handing out relationships with for-profit companies. So I definitely promise that I'll be going over, assuming this makes it through, and making that clear that we never had any intent for that to be the specific company, and that perhaps a different name may make sense. But I don't think that that's a reason to, I'm not even going to make the pun. I don't think that's a reason to not do this. I think that really, this isn't a partisan thing. We have people on both sides that are very heartfelt about specifically what they think is best here. But I think that we should see and try and get this through, because I think that this can save kids, and this will still have further deliberation even after it leaves us, and even if it makes it through the floor.
Representative Weber, and then Representative McLean.
Thank you, Mr. Chairman, and I thank Representative Leon for those words, and I can count. So I'm hoping that whoever writes what I suspect is going to be a majority report on this will say specifically that the members of the committee were pretty unanimous in that. I mean, my assumption is that we're pretty unanimous in not wanting this to be specific, and that will be a further representation of the intent behind the bill. I want to go back to what we have in statute now, and although it has been a long time since it's been revisited, I think we got it right the first time around. And what I am particularly concerned about is the issue of the warm handoff and the short handoff. And I understand that I understand the issue of the shame and the concern about somebody who just can't bear to actually have another person see them do this or acknowledge that they're doing this. But I am very concerned about a couple of things. One is, who knows who's dropped this baby off? I mean, some of us want more people to be able to drop a baby off, but I'm concerned about somebody, perhaps good-hearted, perhaps less good-hearted, dropping a baby off. And how does that work? The other thing I'm concerned about is if we have what is called a warm handoff. You have to hand the baby to a person. There is also somebody there who can be concerned for and care about the parent doing the handing off. And perhaps, one of the things that's my concern is, again, I think we're all concerned about the same things. I think we come to different conclusions about how we deal with them. But the parent who is in despair because they're new at this, the supports they thought they had aren't there, life is currently really awful, they're worried they can't do this. For some people, the act of talking to a live person may show them that there are things out there that will help them and that will help them maintain their relationship with this child if that's what they want to do. And I understand that there are reasons on all sides for wanting different things. I think that having the intervention of a live person is really key for me. And that's why I don't like being disobliging, but because I do recognize the concern that comes out of everybody on this. But that's my sticking point.
Thank you. Representative McLean.
Yeah, thank you, Mr. Chair. I mean, I've been back and forth like a ping pong ball on this thing because so many good points are being raised by both sides. But for me, I think at the end of the day, I think where I'm finally landing on this is ultimately there's just too many what ifs. I 1,000% support the intention of the bill, but I guess for me, there's so many what ifs, and I really don't have the clarity in my mind in terms of how these would play out. But I would almost at this point be leaning towards expanding it out to the 30 days because I think there's value in giving that extra time, but maintaining the warm handoff. But I guess at the end of the day, no matter where you come up, there's just so many what ifs that I don't think this is ready to go at this point. So I think my conscience is not going to allow me to support it at this time.
Okay, we've pretty well covered it. I'd like to move to a vote unless somebody has anything radically new. I'll ask the clerk to call the roll. Motion is ought to pass as amended on HB 1607.
Representative Land,
Yes.
Representative Cushman,
No.
Representative Bill King, yes. Representative Kofalt,
Yes.
Representative McLean,
No.
Representative Seth King,
No.
Representative Moffett,
Yes.
Representative Nagel,
Yes.
Representative Pelosi,
Yes.
Representative Weber,
No.
Representative McKay,
Yes.
Representative Freitas,
No.
Representative Cannon,
Yes.
Representative Nutter Upham, Representative Shapiro,
No.
Representative Merchant,
No.
Representative Long,
No.
Representative Palmer,
No.
Representative Tejas,
No.
and Representative McDonald.
Yes.
9-11.
Okay. Ought to pass as amended, fails 9-11. Is there another motion? Representative Weber?
In light of the confusion and the angst and some of the points about extending the time and I think there are things that we are all really quite in agreement about. I would move interim study so that we could really work on this some more and figure out exactly which components we're agreeing to and which components we continue to have doubts about. So I think it's worth pursuing. I know that the goals are truly important. So those are my reasons for interim study.
I'll second that.
Okay, Representative McLean seconds. Do you want to speak to the motion beyond what you've said?
No, thank you.
Okay. Any other discussion? Motion is interim study on HB 1607. I'll ask the clerk to call the roll when he's ready.
Representative Leon,
Yes.
Representative Cushman,
Yes.
Representative Bill King, yes. Representative Kofal,
No.
Representative McLean,
Yes.
Representative Seth King,
Yes.
Representative Moffett,
Yes.
Representative Nagel,
Yes.
Representative Pelosi,
Yes.
Representative Weber,
Yes.
Representative McKay,
Yes.
Representative Freitas,
Yes.
Representative Cannon,
Yes.
Representative Nutter Upham. Representative Shapiro. Representative Merchant,
Yes.
Representative Long,
Yes.
Representative Palmer,
Yes.
Representative Tejas,
Yes.
and Representative McDonald,
Yes.
19-1.
Okay.
Consent?
I object to consent.
I'm sorry?
I object.
Okay. So that'll go on the regular calendar. Okay, and Representative Kofal, you'll write the minority report on that? Okay. And the ought to pass as amended report. Okay, and finally, last bill to consider this morning is HB 1067. Representative Land, do you have a motion?
Yes, Mr. Chairman, I move interim study.
Is there a second?
Second?
Representative Merchant seconds. Do you wish to speak to your motion?
Yes, please. So this bill seeks to address the problem of women denied hysterectomies primarily because the physician believes that she'll want to have more children, even if she emphatically says otherwise, by not allowing this as a reason to deny a procedure. It also requires that a provider refer somebody seeking voluntary sterilization to a willing and able provider. And lastly, there's protection for patients who change their mind, even though it was appropriately documented that they wanted the sterilization. So while this is a very real and important issue of inappropriately denied care, this is a really big problem to overcome. Most importantly, because it's in the Patient's Bill of Rights. The Patient's Bill of Rights does not have bearing on the individual action of physicians. If we were to say, I had actually drafted some language for an amendment to say that the reason, if the patient was not otherwise contraindicated for the procedure, and if it was simply because of the number of children or their providers thinking that the woman wouldn't want more children, even though she says not, that if she is otherwise appropriately indicated, there's not BMI issues, there's not bleeding issues, there's nothing else, and that is solely the reason, that can't be a reason. Because quite frankly, that's discrimination about the number of children that you think that somebody should have. I had some language that I thought actually was quite good. I sent it into OLS, and then I realized we're in the wrong section of law. We are in the Patient's Bill of Rights, and it's binding on facilities. And it was too late to do anything. We can't have another hearing because it wouldn't be germane. I had another bill where it was drafted in the wrong section. I lost my bill to interim study because actually my bill was killed. It was ITL'd because of that. But we can't change it now. I apologize to the sponsors for not noticing that it was in the wrong section before. Every time I looked at it, I looked at the words. I didn't look at where it was placed. And I'm going to own that error. But that's why I think we should interim study and try and figure out how we can prevent that discrimination because somebody thinks you should have more kids, and separate that out from what doctors do and deciding if you are actually a good candidate for a procedure for medical reasons. So I feel badly to move interim study, but I think that's our only choice here.
Other discussion? Representative Shapiro.
Yes. I found the testimony brought by the prime sponsor and the other people who came to be incredibly compelling and heartbreaking, to tell you the truth. And so I feel bad about not doing anything. But as well as it may be being in the wrong area of law, it's a really, seems like a really thorny question to try to resolve, like how you demand that a surgeon do surgery that they don't feel comfortable doing. Do you want a surgeon to do surgery that they're not, that they don't want to do? So my question isn't whether it's it's really a problem. My question is, I don't really understand the best way to solve it. It's definitely discriminatory in my mind, but I'm not really sure that the bill had a workable solution. So I hope that we can work on it and figure something out in the future.
Representative Seth King.
Thank you, Mr. Chair. So I originally had an amendment that was going to remove the first two sections because I think, quite frankly, there was very little support for those first two sections in this committee. But there did seem to be some support for the third section, which was just basically going to provide immunity for the doctors that somebody couldn't later have regrets that they're going to be sterilized. I didn't reintroduce it today because I was convinced by both the vice chair and the ranking member that it didn't belong in the part that it was trying to stick it into. So I'm going to support interim study. My hope is, and I suspect that the first two parts of the bill are not going to be supported, and that maybe they can just kind of figure out how to protect doctors from frivolous lawsuits and allow them the freedom to perform sterilization without the fear that somebody's going to have regrets later on. That's my hope. I think it'll happen. So that's why.
Thank you. Representative Polozov.
I will be voting against the interim study, and I agree that the bill as introduced is probably too broad, and maybe it has some other issues, but as was said, it's a real and important issue, and as I was told, I was telling during the hearing, I believe that culture has changed, and our culture does not value fertility as much as it was in the past, and medical education also does not value fertility as much as so even though we have some medical professionals who might deny treatment, I think it will quickly go away the way culture and education changed. So I think it's important to pass something like that now because it's real and important issue. Thank you.
Other discussion? Seeing none, I'll ask the clerk to call the roll. Motion is interim study on House Bill 1067.
Representative Leon,
Yes.
Representative Cushman,
Yes.
Representative Bill King, yes. Representative Kofalt,
Yes.
Representative McLean,
Yes.
Representative Seth King,
Yes.
Representative Moffett,
Yes.
Representative Nagel,
No.
Representative Polozov,
No.
Representative Weber,
Yes.
Representative McKay,
No.
Representative Freitas,
Yes.
Representative Cannon,
Yes.
Representative Nutter Upham. Representative Shapiro,
Yes.
Representative Merchant,
Yes.
Representative Long,
Yes.
Representative Palmer,
Yes.
Representative Tejas,
Yes.
and Representative McDonald.
Yes.
And
17-3.
then go on consent.
Is there any objection to consent? We'll put that on consent. Okay, does everybody know, do all the authors of reports know who they are? Or do I need to review it? If there's no questions, or if you want to see me after about anything, let me know. Otherwise, I have nothing else this morning. So we have not scheduled any Senate bills yet. Probably be the week after next. We'll start. What's that? No committee meeting next week. That I know of, anyway.
Do we
None,
know-
and we probably want to see how many people might be stuck in the mud with the solar eclipse too.
That's the other thing. Do we have any indication as far as next week with House sessions?
I believe we're meeting next Thursday. I think the speaker said every Thursday in March.
But
These bills are on deadline next week.
are we
Right.
meeting in the House session for Wednesday and Thursday?
No, just Thursday.
Thursday.
Okay, thank you, everyone. We are adjourned.